Hi, everyone, and good evening, and thank you for joining us today. My name is Dr. Atiya Mossam. You may have heard from me via email, and I am a public health medicine specialist or a public health physician, as we are called in some contexts. I have with me today 3 of my fellow specialists and 2 senior registrars who represent a range of provinces, universities, and roles within public health. The impetus for this webinar was really the large amount of queries that I'm getting from many of you who have joined us today around public health as a career and the differences between public health and a master's in public health. And I thought that this may be an opportunity for us to bring in more voices to lend you all some insights into public health. Before we get into the experience of each of our panelists, I'm just going to give you a brief overview on the difference between public health medicine and a master's in public health, so you are able to understand some of the nuances. I know this is a question that many of you have had, and so it may be useful for us to just delve into this shortly. So a Master's of Public Health is a 4-year university degree that is delivered by schools of public health at many of our tertiary universities. The degree is usually done as a block release where students attend courses every few weeks for the first 2 years, followed by 2 years of dedicated research work. As I said, most people do this as a part-time degree, although you can do it as a full-time. And in terms of the actual scope of the work, some universities deliver a general master's in public health where all the students attend the same courses throughout the entirety of their masters, whereas other universities such as WITS have stream-specific MPHs. What this means is that a university will have all of the students in their first year do a general MPH set of courses. And then when they move into the second year, they move into specific streams. So some of these streams, for example, are management and policy, health economics, maternal and child health, etc. Just in terms of the nuance in how one goes about getting into an MPH. So the degree is open to anyone who has a relevant health or social science background. So it is open to, for example, nurses, allied health workers, journalists, etc. There are usually more spots for an MPH than for public health medicine, but some of the universities do a rotational basis, which means that they only take in MPH students every 2 years due to obviously capacity constraints. Now, looking at what a specialization in public health is, a specialization is also a 4-year degree. And as many of you probably will know, it is overseen by the College of Public Health Medicine within the Colleges of Medicine in South Africa, as well as an affiliated university. So like all of our specializations, you are affiliated to either a tertiary training institution as well as a public facility. So what this means is that at the end of the specialization, you will emerge with a fellowship in the College of Public Health Medicine, as well as a master's in medicine. And this is similar to other specialties as well, where you are registered as a fellow and as well as coming out with a master's in medicine. So as I said, as with other specialties, you are in a training role attached to a public institution and then its affiliated university. So for example, for WITS, and I'm going to speak a lot from the WITS perspective because I trained at WITS, the WITS student registrars are registered via WITS, and the training facility is usually Charlotte Academic Hospital. So the training across the 4 years may differ for the different institutions based on the resources available and the institutions available in that province. And my colleagues will get into exactly what that looks like in the various provinces. But all the registrars at the end of their training are expected to be competent in public health knowledge and skills. And this takes the form of looking at health services policy, strategy and management of all diseases at a population level, especially communicable diseases and outbreaks, epidemiology and biostatistics, health economics and financing, and then research methodology. Registrars in their 4-year specialization will usually attend MPH modules at the affiliated schools of public health to gain relevant theory, and then they gain experiential knowledge through rotations at various institutions, such as, for example, the National Department of Health, provincial departments of health, district health services, facilities and, for example, our national institutes such as NICD or the National Institute for Occupational Health. In terms of training universities for public health medicine, currently these are SMU, UKZN, University of Limpopo, University of Pretoria, Stellenbosch University, UCT, and WITS. To give you an example of how many posts there are approximately 35 registrar posts across the country. So the competition for public health medicine is quite high to get into a registrar post. So with this in mind, I'm now going to hand over to my colleagues who are going to give you just some insight into why they pursued public health as a career, what their training entailed. As I've said, we have specialists and registrars from across various universities, and then where they are working now or where they aim to work, to give you an understanding of the range of careers available to public health specialists. Having said that, I'm going to hand over to my colleague, Dr. Tshegofatso Mamela, who will speak to you on her experience as a specialist. Tshego, over to you.
Thanks, Atiya, and thanks to everyone who's taken the time to come and listen to us and hear our experiences in public health. So I'll get straight to why I pursued public health. I think it's in an intersection between not having found a speciality by the time I was going into community service. I was thinking that perhaps there weren't any of the specialities that I wanted to do, and I had quite a bit of frustration with how health services were being provided in one of the regional hospitals that I did my internship at. So I had a curiosity to find out quite a few things. Firstly, if private practice was better than public service, and then to figure out if, that's a nice little, if private practice was better than public service, and then also whether or not the MPH or the inmate program was more suitable to what I was looking to achieve. I spent some time in casualties and in a wellness institute that helped me understand that what I'm really looking for is to understand how decision-making happens at various levels. And then I think that actually took me to the WITS Community Health Department, where I reached out to one of the senior public health physicians, and there we were able to maybe talk about what would be the benefits of going through the 4-year program. At WITS, we organized the program in such a way that you get access and experience on a day-to-day perspective at national, provincial, facility, district platforms. So we have rotations. They work on a 6-month basis at the National Institute of Occupational Health, where you learn about occupational diseases and social, especially workplace determinants of health. Then you've got NICD, which is obviously the communicable diseases, and I'm sure everybody understood their importance when it came to the COVID response. With exposure to the province, that obviously provides the direction of where, of how national strategies are translated into the province. We've got 2 rotations in academic facilities. First is Barra, so we have a 6-month rotation in Barra, and then we have 2 rotations, so that would end up being a year at Charlotte Maxeke Johannesburg Academic Hospital, and then there are 2 available district rotations at the Johannesburg Health District, as well as the Ekurhuleni Health District. There are public health physicians in both districts, and so you would be under their guidance in terms of understanding programmatic work there and how you implement programs into services from the district health perspective. And then we have a research rotation, and that's really usually because we have an important MED output and short report output that has to be part of the qualification for the college exam. And so that time is usually preserved for you to be able to work on your research. And over and above that, you are obviously a joint appointment, so you have to undertake undergrad teaching. You teach your first year, second, third, fourth year, etc. It's quite it's a busy rotation. It's a busy 4 years. It goes by very, very quickly. Following qualifying in the college, I headed up the information management unit at Steve Biko for about 2 years. And then in 2021, I came to Charlotte Maxeke. So in this role, I am responsible for monitoring and evaluation that has to do with data governance, data management, data products, for decision-making for the facility, as well as the facilities that refer to Charlotte. And then the last question, I'd remembered all three except the last. Oh, no, that's it. I'm done.
Thank you, Teko. And
I need
that
to
was
be
on time. That was just my alarm going off. Thank you for that. Everyone, you are welcome to start putting your questions if you have them in the chat, but hopefully by the time we get through all of our panelists, you will have a lot of your questions answered. To those that are watching on live stream, we are at capacity. So please also, you are welcome to, I am keeping an eye on the Facebook stream. So you are welcome to put in questions into that chat as well. I'm now going to hand over to Dr. Shrikant Peters, who is going to talk from the Western Cape and UCT point of view. Shri, over to you.
Hi, thanks everyone. Thanks for joining in. So firstly, what drew me to public health, so anyone who's a public health physician has been a clinician in South Africa for at least 3 years, mostly actually 7 years historically. And what drew me to public health was really just the difference in the way the system should be and the way the system currently is. So in medical school, obviously, they prepare you somewhat for clinical practice based on, a bunch of boring frameworks that, are very theoretical, primary healthcare approach and all of the frameworks that we talk about in public health. But it's really only when you're an intern and a clinical practitioner that you really see the fact that the system is a washing machine, where you rinse, dry, and repeat your patients. They get sick again, they come back with a acute on chronic of whatever exacerbation they have. And working in healthcare systems without having any input on strategy level or policy level tends to give one burnout. What I was tired of seeing was broken health systems, inefficient management, inefficient systems, poor rostering, difficulties with colleagues, and poor teamwork. And it stood in contrast to what I had experienced as a student clinical manager of Shawco. So where we would take out clinics and be responsible for arranging pharmacists, arranging the vans, arranging student volunteers, and making sure that the back end of healthcare worked so that healthcare practitioners could do their jobs properly. And that's really what drew me to public health. First to an MPH, which I started in community service, and just to test out the waters. The fact that I enjoyed the theory of the MPH led me to realize that this is something I wanted to do full time. The difference, of course, being that the MPH and public health medicine, two completely different worlds. An MPH you join as a paying student. You have to have a separate job, obviously, to keep your bills paid, and you fit in your studies where you can. Whereas with public health medicine, you're paid as a registrar, as any other registrar, but you're paid to learn about systems. Whereas our clinical colleagues would be paid to rotate in the hospitals around the different divisions of medicine or surgery, public health registrars rotate. I rotated in the data center and public health intelligence in the Western Cape. I was able to work on quality improvement projects in different parts of the city and the province. I worked on managing referral systems for all of the medical specialists in the province. And you really got exposed to how finances are dished out, how management structures are created. And my last rotation in final year as a registrar, it's crazy. You're a 30-year-old clinician who is a registrar that gets put in charge of managing an entire department. And I was back at Groote Schuur Hospital. Since then, I've been managing the Department of Anesthesia and Critical Care at Groote Schuur, also responsible for information management systems at the hospital, and managing clinicians who previously taught me in medical school, people double my age, but simply because I have the skill set and the training as a public health registrar, I was given a $500 million budget to manage on an annual basis. And so currently I'm still a manager at Groote Schuur Hospital. I teach quality improvement, clinical governance, systems thinking, and I teach on the global surgery and MPH programs at the university. Thanks.
Thank you, Shri. That was well within your time. All right, so I see there's quite a few questions already coming through, and we will get to them. I'm going to hand over now to Dr. Velile Ngidi, who is from UKZN and KZN Department of Health. Velile?
Thank you so much, Tia, and good afternoon, everyone. Can you see me, colleagues, and can you hear me, just to confirm?
I can see you and hear you. There's just a slight echo. I'm not quite sure why.
Oh, that's strange. I only have one device on. Okay, so I'll just continue. I'm not sure what's going on with the echo. Apologies for that. Good afternoon again, everyone. So my name is Velile. So I am based in KZN. I'm just going to get straight to the questions. So what drew me to public health medicine? Well, for me, the journey has been very, very long. I class of 1999 at the University of Natal, now known as the University of KwaZulu-Natal. And so over the years, similar to what Zeho and Shri have been sharing, it's just years of disillusionment where you're feeling like you're not really making a difference, and patients keep coming back, and you just see them over the years, they get worse. And you just think there has to be something more that we can do. So for me, I think it was more in search of there's something more that we can do to really be on the preventative side of things rather than on the cure aspect where we are hospital-based, facility-based, and trying to manage disease, and yet there's underlying causes. So I think for me, I think then the turning point was when I met my partner, who is quite an activist, background training in political economics. So I got introduced into a world of activism and just really engaging with policy, and it was quite fascinating for me. And I think also fascinating, to be very honest. Somehow I got introduced into the program by a colleague just telling me, I did my MBA first in the journey, trying to find my feet, find myself where I thought I belonged and where I thought I could make a difference. So when I did my MBA, the thought was that maybe if I got into management and got into high levels of the healthcare system and see how I can influence things from there. But I think once I was done with the MBA, I think I still felt that it was not quite. So the MBA that I did was educated. So it was a very corporate oriented type MBA, because I know there are MBAs that have got quite an orientation towards the healthcare type of management, which I think possibly could have been different from me. But after that MBA, I took on a job as a medical manager for 3 years. But then I still realized that there was just so much chaos in the system, and I was still disillusioned. So now I was sitting with an MBA thinking, okay, what's next? I don't want to do another master's, because someone said, oh, why don't you do an MBA then? So I thought, I don't want to do a master's. So I actually called UKZN, and I spoke to now the Dean of Public School of Public Health Medicine, Professor Borge. And she's the one who suggested that, no, why don't you enroll onto the public health medicine program? So I said, okay, so what is this about exactly? Then when I got to understand what it was all about, I thought to myself, okay, this is what I want to do. So then I got through the program. So similar also to what the colleagues of Chris had described. So at UKZN, if you were not registered against a registrar post, you would probably qualify with an MPH because you go through the entire Masters in Public Health program with other master's students who are not in the public health medicine registrar program. So half of what you do then is the theory that covers the entire MPH syllabus, including even the dissertation, which becomes our long report. And then parallel to that, similar to the other colleagues, you also are then attached on a 6-monthly rotation, sometimes yearly rotations at the various levels of the healthcare system. So, for example, I started at King Edward Hospital supporting the CEO's office there. I've gotten involved in so many projects. So the CEO will establish where they've got problem areas, and then myself and my specialist supervisor will go through those projects. It was an enlightening experience, and I really, as the more I got into the program, the more I realized this is exactly what I needed to do, because you are troubleshooting problems and trying to improve programs within the healthcare system, but you've got all of these skills that you are learning in the MPH program that you're getting to apply with support within the healthcare system itself. Then after the placement within the hospital, then I went on to a placement at the district office, and then from there, provincial office. At each level, you got allocated projects, and you get, I think there's a lot of what you learn that is not in the syllabus. This includes how to navigate relationships within that type of environment where you're working with managers at different levels, how you establish relationships, establish rapport, because you need so much support. You learn to be what I've gotten to actually name the health politicians within those environments where you're engaging, making sure that you're establishing good relationships, because those relationships also, even as a professional, they have actually become integrated for me. So then eventually at Providence, I supported a program. I don't know if you've heard of the centralized chronic medicine dispensing and distribution system, CCMDD. This was my last project at the province, where I think the concern was that the HIV/AIDS program in the province was losing a lot of the HIV patients in the CCMDD program, and they were just getting confused how that was happening. And there were issues around, the budget was not reducing the facilities, yet we were referring patients out. But there, when I went through the program, sorry, Asia, are you speaking?
Yes, sorry, firstly, I'm not hearing you very well. I thought it would get better, but it isn't. So I think a lot of people, no, a lot of people are complaining. So can I move on to the other two, and then maybe can you, thank you. All right, thank you, Vi. Hopefully we can figure that out, and we'll get back to Velile. I'm going to move on now to Dr. Masuda Paleka, who is speaking from Stellenbosch and Western Cape. Masuda.
Thanks, Atia. Let me start my timer. Hi, everyone. So yeah, thanks for joining today. I think before I joined the MPH program, well, MPH and then my FCPHM, I'm sure I would have loved something like this to kind of guide my thinking. So I'm going to talk to kind of my story about how I got here. I did my undergrad at UCT, went into my ComServe, well, first into internship, and I worked a bit with JUDASA, the Junior Doctors Association of South Africa. And I learned a bit about kind of the political side of health, the other side of things, the health systems improvement and that kind of work. After I completed my internship, I went on to my ComServe, and obviously working in a busy primary healthcare clinic, you see all the systems issues, and I mean that Shrikant spoke about. And I really tried to see where I could try to improve things. I think it was kind of in my nature, and it really wasn't working out. But I think my story is also a lot about timing. So I, fortunately, during my ComServe year, I applied for the Schevening Scholarship And I then went on to do my MPH at the London School of Hygiene and Tropical Medicine. So I was fortunate to get that opportunity. It was a phenomenal year. And I mean, a very different experience than the MPH in South Africa, because it is only a year-long program. But after doing my MPH, I came back thinking, okay, I've got some theoretical background in public health. Let me try and do systems improvement work. So I went back into a busy primary healthcare clinic space, seeing 40 patients a day, also trying to do systems improvement at the same time, but really being unsuccessful. And again, I think as luck would have it, I guess my path was laid out for me, and I applied for the FCPHM, and I was accepted in the Western Cape. So in the Western Cape, it works a bit differently. You apply to I think it works a bit differently to the other provinces. So you apply to the province directly, and then you get allocated either to UCT or Stellenbosch. The actual service work, the work we do in our rotations, are the same. So we, as Stellenbosch registrars, we rotate with the university, with the UCT registrars. So there's no kind of delineation with that. Where it does differ is our coursework. And so obviously my coursework I did through Stellenbosch University. I got credits from my MPH that I did in London. And so that was accepted over here. But I did choose to do additional courses that I maybe didn't cover, or I mean, some things I kind of just did revision for, things that were important for public health. So I mean, in the Western Cape, I mean, we do 1-year rotations. So we rotate through the district level. So at the either metro or rural areas, you can rotate through provincial level, you rotate through the epidemiology and disease surveillance unit. And so I was involved with, I mean, a variety of things, from COVID outbreak response at the district level, working with people on the ground, to provincial level epidemiology and surveillance, looking things like that public facing dashboard is something that came out of that unit. At the provincial management level, I also worked on a telehealth policy for the Western Cape, and coordinated the writing and the design, writing and planning of that telehealth policy, which is now implemented. And in my last rotation, I really wanted to be closer to the ground and work directly with facilities. And so I chose to do a sub-district level rotation, which is kind of one level up from our facilities. And so I'm still in that role in my final year of my registrar time. And I think what I enjoy about this level is you get to still work with clinicians, and you work with the facilities, you kind of see the impact of your work on the ground, but you still get to do policy work and systems improvement, and that kind of thing. You kind of, for me, it was a full circle, because I'm now working at the management level in the same area that I was working as a clinician. And so I think for me, having had that experience as a clinician, working in this busy primary healthcare setting in this sub-district, understanding the challenges, has really benefited the work that I'm doing as a public health clinician. I think having that clinical experience is vital, because you do need to understand the systems. You do need to understand what is wrong and why it is wrong, to be able to kind of change it from the other side. So yeah, I mean, I think this is where I am now. This is what I think I've found my place in public health. One of the good things about public health medicine as a specialty is that it's so broad. So you could be, I mean, like I'm doing, working at one level up from the facility level, working with facility managers and clinicians, doing health systems improvement. You could do medical management like Shrikant's doing. You could be in epidemiology, doing biostats and epidemiology work, working with the numbers, working with the data. So I mean, the spectrum and the opportunities are really, really broad. And I think, I mean, I'd encourage, I'm so glad that I found my space in public health, and really would encourage anyone who's interested to kind of join the fold, and ask questions and find out more. Thanks, Atya. That's my input.
Thank you, Masida. I think we have lost Dr. Inga Kleinans. She's having a problem connecting, which is part of the course with these things. So what I'm going to do while we hope to get her back. Oh, are you back? Inga, are you here? Inga?
Hi, good evening, Atia. Can you hear me?
Yes,
Wonderful.
go for it.
Thank you so much. Good evening, everyone. I have the wonderful opportunity to share my brief experience of public health medicine as a registrar in training in South Africa with you. And as Atia was saying, I'm Dr. Inga Kleinhans. I'm a senior registrar, similar to Masuda in Gauteng at Sefako Mogatsa Health Sciences University. And I have the opportunity to share with you a brief overview of why I chose public health medicine and my key interest in this field, and then a brief overview of the training and learning outcomes, rotations, some successes and challenges, and then some registrar readiness recommendations for those coming after us. So overall, we know that the PHM Registrar Training Program is one of the vital components to producing public health medicine specialists in our country, or otherwise referred to as physicians, as already mentioned by our previous speakers. So personally, my interest in public health medicine was sparked in my second year of my undergraduate training when I was introduced to the module An Introduction to Public Health in our medical training. And so as a child growing up, I had the unfortunate event where our family experienced quite a poor health event, and this changed and shaped my view on the health system quite tremendously. So I always had this big dream of becoming an engineer or mechanical engineer, aerodynamic engineer, but this really changed my hopes and my dreams, and I knew I had to do more. And so it drove me to take on the career path of medicine. And I knew that what I wanted to change and what I wanted to do was to strengthen the health system in a way that events like these never happen again or to anyone else. And so essentially, when I was introduced to this module as an undergraduate student, I realized that this is the particular career path in medicine where I see myself specializing one day, but it is a difficult decision to make, and you have to be really sure to take up that journey, and if you're ready to leave clinical medicine behind. So since then, I've started involving myself in various extracurricular public health activities. I was part of the co-founding team and the initial committee for JUPASA. I did some pandemic response work under supervision through knowledge translation throughout the pandemic, and I also joined an international NGO organization, Women in Global Health, and taking up various leadership positions in other organizations as well. And so this strengthened my public health passion for system strengthening, policy and advocacy. And so overarching, in terms of my experience with the registrar training program and some feedback from others, that the registrar program, when you do get in, it's like everyone said, it's 4 years with a minimum of 36 months before exam if you meet all the requirements, and that this does entail academic teaching, both postgraduate and undergraduate, with research as well as service delivery throughout your rotations. And that rotations are generally done under the supervision of a local and a site supervisor, which are generally PHM consultants. It's such a vast and extensive field, and training programs generally align with our college outcomes and skills list, and we generate portfolios of evidence in each rotation. So there are some core similarities between institutions, but there are also some key differences. And so, for example, we cover rotations such as health management. My own was at a teaching hospital associated with Sefako Mogatsa University, and this is Dr. George Murray Academic Hospital, where I covered an array of organization management and policy skills. I was involved in strategic planning, operational planning, exposed to SOP generation, quality assurance, etc., and really learning about the functional units of a health establishment. And then we were exposed to health measurements throughout modules, which we did. We also have a REMI course, which is a research methodology and biostats course. Social sciences, which we are engaging in throughout our modules, our rotations, and it across our learning experiences. And then I also did a communicable disease rotation at the NICD, where I worked on malaria, rabies, COVID, and overall public health surveillance and response activities, non-communicable diseases, which we touch on in all the other rotations as well, environmental health through our district rotations, and then occupational health, which I did under the supervision of the HIV and TB unit in the workplace at NIO. I also had the fortunate opportunity of doing elective rotations through the NHI, SAMA, and the OHSC. And then I would just like to briefly summarize some successes and challenges from colleagues over time. And the successes includes the fact that we do have strong support structures in certain institutions which emphasizes teamwork and experiential learning, which is inevitable and very important in the professional development of registrars. And then some challenges includes the need to be cognizant of prioritizing work based on workload. The differences, there are some differences between programs, and the need for standardization might be proposed. And like I said, core rotations overlap. And there's also a lack or limited opportunity for overtime. Some registrars do no overtime, some do clinical calls, medical legal calls, and hospital management calls. And then just some final words of wisdom to those who want to embark on this journey. You need to really have a strong support system because of the overtime challenges, that you might need to have financial readiness or awareness of your situation before taking up the post. And if you are considering a PHM career, please reach out to specialists on the call to do internships or shadowing to see what it is that they do in real time, so that you can see if you're ready to do this for the next 50 years. And then know that this journey is the start of your journey towards health system strengthening based on where you see yourself, but know that it takes time to get there, and then inevitably you'll be a strategic disruptor to make the difference you want to see. Thanks. Over to you, Atia.
Thank you, Inga. And thank you to everyone for sharing the sort of quick whistle stop on their careers. I assure you, many of the people on this call have probably in excess of at least 10 years of clinical time, and probably just as much experience in public health. There's quite a few questions in the chat that we will get through. I just wanted to say from my experience, I know there were questions around the MPH and the MEd, and whether or not you will get credit. So as someone who did an MPH and then went on to do an MEd, and I did both of them at Wits, the credit that you will get is in terms of the courses. Unfortunately, you will still be required for your MEd degree to do the research component of the MEd again. So there is no getting away from it. You may, as I said, you may be allowed to take other courses, or you will be credited for the MPH courses that you have done. But in terms of the research report, you will have to conduct a research report as well. And just to say that the research that registrars are expected to do is quite a robust research endeavor compared to, in my experience, compared to what I've seen is required for other MEds or for MPHs, because it is really a core part of our work. So if you would like to pursue a registrar time and are not very keen on research, just know that that is a core component. And then just to say, in terms of career, I know there were questions around, can you work outside of government? There are a range of public health practitioners across the entirety of the health service, many of whom have done an MPH, many of whom have done a specialization. I myself work as a global consultant for public health, and I'm an independent consultant. I have clients that contract me for technical services, and I work across continents, across different contexts and countries, and looking at a range of public health related technical advisory services. So from policy development to implementation on the ground, assessment of health services, quality improvement, really the gamut of public health. So I think what you can get from most of our speakers here today is that it really is quite a broad field. There's many ways to skin a cat in terms of public health and getting into public health. It really is up to you to, unfortunately, in some ways, it is up to you to sort of carve that path going forward. I will say, though, for those that have asked, and I know there was a colleague that said that they've had an MPH and are struggling. This is what was told to me, and this is partly the reason why I pursued a specialization after an MPH. I was told by a senior colleague who is also a public health medicine specialist that doctors with a public health, an MPH, do struggle to find jobs because you are a relatively more expensive resource than someone else with an MPH. And so employers may not be willing to give you a job if they had basically two people with an MPH and somebody else would potentially be cheaper. So that is what was said to me. And then also, obviously, as a specialist, you can demand a higher salary. So this may not necessarily be true for everyone. I certainly was not able to find a job after my MPH, and so I went on to specialize. I'm not sure if my colleagues have different experiences, but that was mine. So having said that, I'm going to ask all of the colleagues to come back onto camera, and we will take some of the questions that have come through. So I don't know if anyone wants to talk about how best to bolster your CV regarding to get into the 35 very limited posts that we have across the country. And I think just to say to all of you, the other thing is that these posts, there's probably 2 or 3 posts that become available a year as registrars write. We generally don't have a lot of registrars writing at the same time. So, and I know maybe Tejo and Shri, who are involved in the universities, may know exactly how many applications are received, but I know it is quite a large number of applications for the amount of posts that we have available. So it is quite a competitive process. And I think bolstering your CV and getting some public health experience or some knowledge behind you will serve you in good stead to get into public health. But does anyone want to weigh in on that question? Yes, Shri, go for it.
Yeah, no, I would say that the gold standard or silver standard before starting Reg Time is to join the MPH program at the university that you're looking at doing your Reg Time at. Experience of the community health system, of district level care, of primary health care would stand you in good stead. Any interaction with facility management, any work done on quality improvement or working with some data operationally would be of use. And obviously formal publications for any specialty would be very useful. It's assumed that public health is research, but it's not. It's really use of data to inform decision making and improve efficiencies and outcomes of the service. So if you've proven that you can do that, and you've done that in a team, and you've done that for management in your facilities, and you're thinking broader than just the one patient in front of you, that looks very good on a CV. Yeah.
Thanks, Shri. I was going to add something, but now I completely forgot. When I remember, I will get to it. There was a question also about what do registrars do on a day-to-day? What are the duties? So I'm going to hand that over to the registrars who are, probably the most appropriate to answer that question right now. I'm not sure. You can both go, so I don't know who wants to go first. Okay, since you're both staring at me, Masuda.
I think we were both polite, so we wasn't sure who's going to go first. Yeah, I mean, I think I'm as a senior registrar on a day-to-day, I do the work pretty much of a specialist, of a public health medicine specialist. In fact, my boss calls me the public health medicine specialist in our at our substructure, which is what is the area that I'm working in at the moment. So on a day-to-day, so I mean, I think today, if I could just go through a normal day, usually there's a lot of emails that you have to get through. There's also the mundane meetings. So there's often, if I'm working at the sub-district level, so there's a lot of regular facility-based meetings, but then also facility manager meetings. So meetings with our facility managers and operational managers to understand what the challenges, issues, and also the good work that's being done across the service. we have a few our kind of own management level meetings. So there's a range of meetings that we'd have, and I usually attend either on a weekly basis, on a bi-weekly basis, or on a monthly basis, and also some are quarterly. But essentially those meetings are to touch base and to monitor the progress of any work being done, any challenges, anything that we as the health management for the area need to step in on. So that kind of work. And then I'm doing a lot of project-based work now. So I mean, some I never thought that I'd go into schools and talk to learners in schools, but one of my big projects this year is working on an integrated school health program for our area. So we have the policy, but it's really it's quite variable in terms of its implementation. So another big part of our work is implementing the policy. And to do that, sometimes you do have to get your hands dirty and go out and, be kind of really part of the system to understand the issues and then see how you can change things from that level. So, I mean, that's in a nutshell, that's kind of what I'm doing at this level. Thanks.
Thanks, Masuda. Inga?
Yeah, thanks for that, Atiyah. And I think Masuda has captured it brilliantly. I think it also depends on, or just to highlight to the audience, that it depends on where you are rotating. So, for example, if you are at the NICD, you would work on some surveillance projects. And like Masuda said, a large part of your day consists of catching up on emails, administrative tasks, attending meetings. These meetings might be organizational, or it might be external with stakeholders where you are included or invited to sit into those discussions to learn from those meetings as well. And then also internal meetings to discuss the projects that you're working on with your local site supervisor as well as your department supervisor. So over and above the administrative day-to-day tasks that you have, there's also teaching responsibilities. So you might have weekly lectures that you are scheduled for, and then of course your academic days, which are depending on the institution. For example, ours are on Fridays, so Fridays are holy days. You only do academics on that day. And then, every other week, it depends on your rotation. So you have rotation specific activities. Sometimes you might also be requested to do service delivery tasks, depending on your pay point and your institution where you are employed. And then you concurrently deliver some of those tasks if there's a shorthand or if there's a dire need. For example, an outbreak. For example, we had a cholera outbreak in Gauteng. We also had the pandemic. I mean, so all hands on deck in those instances. So it's rotation specific, but a large proportion is administration, and then rotation specific tasks, and then academic responsibilities. Thanks, over.
Thanks, Inga. All right, so we've got like 13 minutes left, and there's a lot of questions. So I want to try and get through as many as possible, because I know, and just to say, I think we're probably going to have to do this engagements quite often. We've had to not let a few people into, and hopefully people are still looking at watching the live stream. So we will have future engagements. I see Daniel's got his hand up. Daniel, would you like to just ask your question briefly?
Yeah, can you hear me?
Yep.
So I had two questions. The first has been pretty much asked, but I just want an opinion on what public health professionals think of clinical specialists who then have lots of experience in a clinical field and then try and get involved in public health thereafter. For example, just hypothetically speaking, say a district pediatrician that's spent the first half of their career working in peds and pediatric service provision, and now wants to use that experience to make policy on a broader level. And so what capacity is there for them to get involved in public health, and are any sort of qualifications expected from people that give jobs to public health professionals?
All right, thanks, Daniel.
Yeah.
All right, so I just want to say, I know, so Daniel did send this question to us beforehand, so Tseho is going to answer it. But I do want to say, and this is in relation to another question that was asked about the different roles. And I think the one thing I just want to underpin is that there is space for everyone in public health. You'll see us all nodding, because there is a cadre of, we are public health medicine specialists, but there's a cadre of healthcare workers who are public health practitioners. And that is quite a wide range of people, from, really people working in communities all the way up to people working at the global level. And so everyone comes with their own experiences and their own unique lens of the health system. And so we don't view anyone as being less than. I think, just to say, the public health medicine specialty gives us a unique view in that we have worked in the health service and we have worked at population level. And so we can really see the articulation between those two. And that is really the uniqueness around public health medicine. That does not mean that any other public health practitioner doesn't have any other value. So I just want to say that. So if there is I will say personally myself, I learned public health from a family medicine specialist. That's where my journey to public health started. So really there are different ways that you can approach public health. This is just one of them. So having said that, I'm going to hand over to Tejo, who had some reflections on this.
Thanks, Daniel, for the question. And I think it also covers health practitioners who aren't necessarily medics, but are interested in expanding their practice into public health. So that this might also answer some of those questions. There are so many population health problems that we have. We need as many eyes and skills and competencies on responding as possible. I would say that being in the facility, in the academic facility, I've seen, in fact, most of our heads of departments are actually public health systems thinkers. After 15, 20 years of seeing problems from a systems perspective, they end up coming with strategies that actually are public health responses as opposed to clinical responses. What I've also noticed is quite a few of our HODs have not only finished, obviously, being these incredible academics in their areas of expertise, but have added a Master's of Public Health to their competencies because they want to respond in strategic, systematic approaches. So whether it's from a district level, facility, or provincial level, I think that kind of view and expertise actually enhances the response of the health system as a whole. And I would advocate for anyone who's interested maybe in continuing their service or their health practice, but to also have a lens of a systems approach or a systematic approach or a policy approach to then add to their qualification something like an MPH, because then you can use that policy thinking or health economics thinking or whichever area you want to specialize in to then provide meaningful responses in terms of what you see at a population level, also largely informed by what you see in clinical practice. So there is a continuum that sits between what you see in your consultations, what you see in the facility, what you see in the district, province, etc. And if you want to have that very clear response, I think it is valuable. Doesn't matter if you're an MO, if you're a junior consultant, if you're a senior, if you're an HOD, to have that particular lens to help you articulate what you need, either provinces to put budgets to or CEOs to prioritize and programmatic operational plans. I think it just gives you a language that a system that helps advocate for where you are in services and what you want to see achieved in population health. I hope that answers it.
Thanks, Tejo. All right, so Mesra, I'll get to you now. What I'm going to ask each of you to do, there's many questions there. Please just have a quiz through the chat. I'm going to give each of you a minute to maybe just do your last reflection in relation to some of the questions there. I do want to say quickly, I remembered what I was going to say earlier, is that many people ask if there is if there's any, again, there's these questions around like dividing us as a public health community, and people will ask, well, what's the difference between someone with an MPH and someone with a public health medicine degree? I will just say, from a training perspective, if we had to take a community service doctor and send two community service doctors and send one of them to do an MPH while working in clinical services and one of them to do a specialization, for me, and colleagues can feel free to disagree with me on this, the nuance for me is that when you come out of a specialization, by virtue of the fact that you've done the MPH courses and you have worked in the services in a role, in a public health role, you can hit the ground running because you've actually learned how to do the things. For example, when I was in a public health, doing my master's in public health, I was still working clinical medicine, even though I was doing some sort of public health type work. I didn't really have the mandate. And so I didn't get the chance to actually practice my public health skills. So that for me is the nuance, is that you get that if you liken it to clinical medicine, it's like learning pediatrics by sort of reading a book and not getting a chance to actually, see patients, versus actually being able to do that in the service or in rotation. So that for me is the main nuance, is that public health specialists, once you come out of it, you've actually had a lot of experience doing the actual work, whereas an MPH is in many ways more theoretical. So having said that, I'm going to do now a quick round. I see we have 5 minutes left, so 30 seconds each, or like 45 seconds each. So I'm going to go in the reverse order now. So I will start with Inga. Inga, over to you.
I think just in brief summary, I know there's a lot of people who has a passion for public health and someone to embark on this career. And I see some of the questions has to do with career pathing and mentorship and possibly exposure to the discipline. So I'm willing to put my email in the chat. If anyone wants to reach out, then I can try and connect you with different consultants and see how we can best expose you to see if you are willing to do this and take up this career journey. So my email is in the chat, and you're welcome to contact me. And I'll put you into contact with the different consultants across the country based on where you are. Thanks, over.
Thanks, Inga. Masira?
Thanks, Atya. I think it just came off something that Chippo said. I was thinking that it's easy. Well, I think me even just reflecting on my time as a clinician, it's easy to criticize the system. When you see one patient at a time, you're sitting in your office surgery, or going to one patient bed at a time, treating them and moving on. And I think even from my side, I'm guilty of that. And I'm like, how hard can it be? You must offer a service, let's just get it done. But really now, on being on the other side, it's you realize the complexity around health, the politics around health, and everything else that comes with it, and all the other issues that management have to deal with: financing, budgeting, supply chain. I mean, it really is endless. And so I think, as many of the colleagues have already said, you do really need to think considerably about the move into public health, because it's not all rosy on the other side. But it really is fulfilling, and it's really good system-wide work when you can really make impactful change. Thanks.
Thank you, Masira. V, I hope you are not echoing now.
Oh my Lord, how is that now? I tried to move from where I was sitting.
Oh,
Still,
I think it's probably
no.
your computer.
I'll just type. It's
Okay, type fast. Thank you, V. Shri, over to you.
I think one of the questions I was just telling in the chat was whether or not doing an MPH allows you to decrease the time of your training. And I think it made me realize this is really not something that is a chore to get through. If there's anything that I realized about public health, Friday night I was covered in blood in Hillbrow Clinic as an MO, and Monday morning I was next to a computer answering emails, not sure what exactly I was doing. But 6 months in, I loved my life. I loved what I was doing. I enjoyed implementing health records in facilities and talking to senior clinicians and thinking about what the health system should look like in 10, 15, 20 years' time. It's something that you want to do. Registrar time it's not easy, but it's very fulfilling. And it's work that I've actually loved doing. It's everything that I wanted it to be since leaving clinical work. And being in medical management, I still get that experience of being in touch with the ground and helping healthcare workers make things easier for themselves and for patients. So yeah, very fulfilling work. Thanks.
Thanks, Shri. Tshepo?
Thanks, I think my point of departure is to encourage people to know what it is that they want to get out of a career in public health. There's so much to learn in this field. Perhaps, you know, knowing what it is that you want to get out of it helps you understand which road you should take. I've certainly found a lot of interest. I'm interested in many projects. I am interested in both the clinical, the non-clinical, the health. So I love the variation of exposure that you get, and your ability to then translate it not only for yourself as a physician, but also to support your colleagues who need that sort of articulation for their service.
Oh, T, you have muted yourself.
So I would encourage,
I
if
thought
you are
our time was up.
sorry, as long as you're curious and you are willing to learn, it's a long road. Shri said there are 10, 15, 30 years sort of projects. If you're patient, it's fine. But if you're looking for tomorrow's solutions, you might get a little bit frustrated with public health because there are a lot of politics and you know, other levers that you have to actually pull on, and engagements you have to make sure that you engage with before getting solutions that are actually going to transform health services and health systems. Thanks.
Thank you, T. All right, I see we are on the hour, so I'm going to close now. I just would like to say to everyone, I will send around a link to the recording if you would like to rewatch this. There is also the Google form that I circulated to everyone. You can drop me your, because I won't be using your email addresses going forth. You can drop me your email address in that Google form, and we will try and circulate some resources around the universities that are training, and maybe some contact details for people to contact at the universities if you'd like to be put onto lists for, you know, when they advertise posts, for example. I'm not sure all the universities have that, but if they do, I'm sure they will be able to direct you to the processes that they have. Having said that, we look forward to having more engagements. I think there's many still unanswered questions, so we probably will have more engagements regarding this soon, and I will keep you all posted. And thank you to my lovely colleagues for joining us today, and to spending some time just, you know, helping people understand this very murky world of public health sometimes. I hope you all have a lovely rest of your evening, and we will chat soon. Bye, everyone.